We're starting to understand both on the very acute and also on the recovery side that actually probably less dialysis is better overall for the patients, but that we do have to intervene in a timely manner, right? Because delaying it too long, right? There's this kind of like
sweet spot,
kind of Goldilocks kind of period. Yeah, sweet spot. Too early or too late can actually be counterproductive.
This is the Sepsis Spectrum, a podcast about antimicrobial resistance, sepsis, and how to expect the unexpected in your practice.
My name is Josh Woodward.
And this is Chelsea.
This is my wife, Chelsea Woodward. And I'm going to talk a little bit about our sepsis journey today. I remember right around February, maybe 2nd or 3rd, I clocked out of the firehouse one day. I was feeling a little bit under the weather, but I wasn't really alarmed. I was, had a low-grade fever of maybe 99, so not too terrible, a couple of aches. And I had a spot in my right armpit right in here. As the days progressed, things kind of started to get worse. There's another spot on my ribs, and that spot is the same thing. It's red and it's swollen and kind of painful. So, my wife came down. She saw it around 5 a.m. I was still awake. And she's like, why don't we just take you to the ER? I remember one of the first signs I noticed, that I didn't realize it at the time, but looking back on it, I always mention it because I used the restroom before I went to the ER. And I remember that night, I didn't sleep and I drank like over a gallon of water, feeling so thirsty, but never having to feel like I had to use the bathroom. And I went to use the bathroom before I went to the hospital, and my urine was like as dark as I've ever seen it, like iced tea, like brown. So I was like, well, that's kind of alarming. So I got checked into the hospital. Next thing the doctor's coming in telling me that I'm going into septic shock and they need to operate on me right away. And that would be about a 2 to 3 hour surgery to open up some of the infected tissue and see what was going on. I said, okay, but I woke up not 2 to 3 hours later. I woke up 10 days later. 10 days later, thinking it was the same day. So as it stands now, I'm a double amputee. As far as kidney treatments go, I had some pretty severe kidney issues going into it. I thought I was going to be on dialysis for a long time. I was on dialysis 7 days a week for roughly 3 or 4 weeks while I was in the hospital. Luckily, when I got out of the hospital, I didn't need dialysis anymore. But I have been much more conscious of the things I drink, how I continue to take care of my body. If you're worried you have sepsis, this is your life. This is your body. So take the initiative, go to the hospital. And if you're worried about them missing it or like missing something or passing it off as a flu, just say out loud, like say it to the nurse, like, hey, I'm worried this might be sepsis. Just getting that out there will really get things in motion and get things moving along.
Hi, everyone, and welcome to the Sepsis Spectrum. I'm Nicole Kupchik, critical care nurse, clinical nurse specialist, and your guide through the unpredictable world of sepsis, or as we like to call this season, sepsis and multi-organ dysfunction. Today, we're turning our attention to one of the body's most silent but vital players, the kidneys. More specifically, taking a close look at the relationship between sepsis and kidney injury, and how infection, inflammation, and fluid shifts can quietly overwhelm one of the body's most resilient organs. The clip we just played was from Josh. Josh is a firefighter and sepsis survivor who went from a few red spots on his skin to full-blown septic shock in just a matter of days. His kidneys failed, his body shut down, and for weeks he relied on dialysis to survive. Josh's story is a huge reminder that when the kidneys falter, it's not just a lab value on a chart, it's a turning point. Fluids build up, toxins rise, and the balance that keeps every organ stable begins to collapse. I'm fascinated by what's happening inside the kidneys during sepsis. So it's a perfect time to be joined today by Dr. Gonzalo Matzumura, assistant professor of medicine in the Division of Nephrology at Washington University School of Medicine. Dr. Matzumura studies how sepsis disrupts renal perfusion, damages tubular cells, and triggers inflammation that extends beyond the kidneys. His work sheds valuable light on why early recognition, fluid management, and renal support can make the difference between recovery and long term disease. Coming up, the kidneys, how they act as both victims and amplifiers in sepsis, how to interpret the early warning signs of renal failure, and what recovery really means once the filters start to fail. Stick around, we'll be right back with Dr. Gonzalo Matzumura. I am so excited today to be joined by Dr. Matsumura, who is a nephrologist and the associate professor of medicine. So, welcome to the show.
Thank you. Thank you for having me.
All right, I am so excited to dig in. So, you do a lot of clinical work at the bedside, and you see septic patients who commonly have acute kidney injury. I bet you spend a lot of your day writing orders, I'm just going to assume for either CRT, continuous renal replacement therapy, or for hemodialysis, who've undergone, septic shock or sepsis.
Yeah, that's correct. So I think probably the most common indication for or the bulk of the patients that we see on the inpatient side in the hospital has to do with AKI, and particularly severe AKI, right? And out of those patients that have developed severe AKI, a large portion of them are patients that have had sepsis as the underlying cause, right? Probably AKI in the ICU happens about half of the time within the first week of admission in those patients that develop AKI to the point that it needs some form of kidney replacement therapy. Mortality can be upwards of 50%. So AKI is a pretty significant sort of disease, sort of modifying factor that can affect prognosis of a lot of critically ill patients, right? And in the particular case of sepsis-associated AKI is the most common cause of AKI in the ICU, right? 45 to 70% of patients that develop AKI in the ICU can have an underlying diagnosis of sepsis. And because of that, we have to be sort of very, very aware of it and also try to be as proactive possible in managing, because that can help prevent long-term complications. Because I think the problem with AKI is that people sometimes think about it just as a sort of like biochemical and transient abnormality. But I think we are increasingly more and more aware that the effects of AKI extend far beyond just sort of the episode of AKI itself. We know that patients, you know, with AKI, if they recover from this kind of acute illness, they could progress to something like CKD. They could also sort of have they have decrease in their quality of life, and they have even increased mortality within that first year after that episode of AKI. So there are a number of. I think the paradigm for AKI is changing a little bit in that it's just not like, oh, this transient episode and if things are okay after this, but it's we have to try to prevent it and also be very aware of the patients that have suffered AKI so that we can do anything that we can to sort of improve their long-term health outcomes.
So, I guess when you think about prevention, what do you think is causing a lot of the AKI? Do you think it's hypoperfusion, hypotension, and shock, or is there something more? And is there a stronger tie with sepsis that's actually leading to kidney injury?
Yeah, I think that's a really good question because for the longest time, I think the paradigm or our understanding of AKI that happened in the setting of sepsis was kind of this generic insult that would lead to hypoperfusion, low blood pressure, less blood flow to the kidney, acute tubular necrosis, and that's how AKI would come along. But I think as we start understanding sepsis a little bit better and also defining AKI and sepsis better, we're starting to realize that it's much more complex and heterogeneous, right? And it's way more multifactorial. So there's definitely some sepsis specific factors that are at play there. Things like sort of inflammatory injury from cytokines and sort of immune cell activation. We know there's some degree of microcirculatory dysfunction as well, with kind of blood flow being shunted away from the kidneys. There's at a cellular level, there's mitochondrial dysfunction too, and even some bacterial products or inflammatory products can actually cause direct endothelial injury and tubular injury, right? So, kind of thinking about these sort of factors that are irrespective of blood flow, I think has allowed us to think that there could be some other potential therapeutic targets to managing sepsis-associated AKI, right? And then, um, to make things, I guess, more complex, there are some factors that are associated with the treatment of sepsis itself, right? So we know like certain antibiotics can be nephrotoxic. So in a kidney that is already kind of suffering, we add on nephrotoxic medications and things like antibiotics or patients that have been on RAS inhibitors before, or vasopressors themselves will cause worsened renal perfusion. So I think it is way more complex than just this is a patient in septic shock or hypotensive, and because of that they've developed AKI. There's sort of this whole these other factors that we have to be very keen, and that allows us, I think, to risk stratify these patients even before, to kind of be able to identify like, oh, this patient has risk factors for AKI, like they have underlying CKD, they're diabetic, they are hypertensive, they have a smoking history, and so hence they're probably going to be more vulnerable and susceptible to developing AKI in the setting of sepsis.
Which makes everything just so much more complex, right? When they've got these big histories. So let me ask you just a super quick question and with a super quick answer. So for those of you who are listening, who work at the bedside, so some advice for those people. What are the antibiotics that you look at their list and you're like, shoot, like that could really harm their kidneys? Like we always think of like Vanco and gentamicin, but like what other ones?
Well, I would probably say most of them when dosed correctly, but that's the other thing, right? That is this whole kind of other topic, really, that the way we dose antibiotics in AKI is really complex, right? Because a lot of times we're going off, and this is kind of we're going off on a tangent here, but um, you know, the way we assess clearance and kidney function during an episode of AKI, when kidney function is changing by the hour or by the day, is really imperfect, right? So we could be dosing antibiotics correctly for a specific GFR, but it very well might be that that's actually not the patient's true GFR, and we actually are overdosing, and in the process making, causing more damage. I think, as you kind of pointed out, yeah, the ones that we are definitely much more aware of and that we know have a direct sort of effect on the kidneys tend to be vancomycin and aminoglycosides like gentamicin, amikacin. Antifungals like amphotericin we know also have sort of this direct nephrotoxicity. There are other antibiotics such as beta lactams that can have more kind of like an indirect effect when they're inducing something like acute interstitial nephritis, but not so much so directly on the kidney. But I think the larger sort of problem is that we really have a hard time assessing what the patient's current kidney function is during an episode of AKI, just because we don't really have the necessary tools to, and all of the dosing guidelines for these antibiotics have been done in steady states, right? Where the creatinine is stable, where it's not changing hour by the hour like it is in the case of AKI. So it's almost like we're just kind of our best estimate or guess when we're dosing these antibiotics in AKI.
Well, and I think with that said, I mean, you're an expert, right? The kidney is, you are an expert. And do you ever feel frustrated that you get called so late in the game?
Yes, and I think that is a big problem of the way, or just kind of how we are defining AKI in general, right? KDIGO, which is kind of the big organization that provides guidance for kidney related diseases, defines AKI with basically two parameters, and that's creatinine and urine output, right? But we know these two markers tend to be flawed because creatinine is sort of lags behind a lot of times, right? There've been these experiments when so we typically expect a change in kidney function when creatinine rises, but a lot of times the kidney function is already changing or the patient is undergoing AKI and the creatinine really hasn't started to change. So it lags behind 24, 48 hours.
Is it that much?
Yeah, 24 to 48 hours. It's pretty amazing to think that, so by the time that the creatinine starts rising, we already, it's kind of the horse has left the barn already.
Oh, because it's so funny. In my head, I knew there were lag times. Like I knew that was a thing, but I had like 8 to 12 hours in my head. So you're saying it can be up to a day lag time.
Yeah, up to a day later. And we have to also, the other important thing is that we lose, in order for creatinine to start changing and rising, we have to lose a substantial amount of kidney function. So if there's kind of small changes in kidney function, the patient could already be having some AKI, but maybe the creatinine's still not going to rise.
Yeah. All right. What are your thoughts about EGFR?
Yeah. So EGFR is kind of the way we try to assess, kidney function, right? So it's using creatinine as an indirect marker to sort of try to get as close as we can to the actual EGFR. But um, there are hopefully kind of technology and sort of different biomarkers that are coming along that should help us or could allow us to have a more precise definition of GFR. Cystatin C is an upcoming functional biomarker that tends to have a shorter half-life than creatinine, so it'll change faster than creatinine, and it tends to be more precise because it's not affected by other things like drugs or patient's muscle mass as creatinine is. And there are also some of these real-time EGFR sort of markers coming to the market hopefully soon. So, with these incoming technology, I think we'll be able to better quantify or better assess kidney function, so that maybe we can find, places where we can intervene sooner. Because I think that is part of the problem, that we're reaching these patients way too late. By the time that we think they have already developed AKI, um, you know, our interventions are limited at that point.
Well, it's so funny. I worked with this amazing nephrologist for years, and he'd walk on the unit and he had this really gruff voice. And he'd be like, Nicole, why didn't they call me 2 days ago when I actually could have done something?
Yeah, yeah,
I'm like,
yeah.
I know, I wasn't working that day. I would just tease around with him. But it's true. And that was one of his frustrations, is like he just got called so late in the game. Basically, he would get called at the point the patient needs dialysis and has such a metabolic acidosis that you're like.
Right. That's so severe that there's nothing else to do.
And so, I mean, I think if anyone's listening, especially any intensivists or hospitalists, it's just something to think about. Let's think about our nephrology partners a little earlier.
Yeah, yeah. And I think part of it also, to be honest with you, though, Nicole, is that the way we've understood sort of AKI and the lack of therapeutics also kind of warranted that approach a little bit, right? Because they'd be like, well, nephrology is going to come along and they're going to be like, well, we'll just monitor until we actually need dialysis, right? So I think we've kind of gained a little bit of that reputation, but I think that is starting to change, right? Because the better that the more we understand sort of some of these underlying mechanisms, and the fact that this is just not a hemodynamic injury, I think also the sort of the advent of some of these new therapeutic targets, right? So if we target inflammation, there are some sort of clinical trials that are coming out that some anti-inflammatory medications, certain steroids or recombinant alkaline phosphatase, or sort of some more novel vasoactive drugs like angiotensin II, used in the right setting early on, can sometimes protect the kidney from worsening AKI, right? But I think we are just starting to have some of these tools, so that even if we're able to identify AKI earlier, then we would be able to do something about it, rather than just like, yes, this patient is developing AKI, but we'll just probably have to monitor, right?
Well, and there was some really exciting smaller papers that were published after the Athos 3 trial that evaluated angiotensin II or Giapreza as a vasopressor. And again, finding that right subset of patients who would actually benefit from that as a vasopressor.
Yeah, yeah, and I think we are going to be. Hopefully, you're right. So it's all about the right patient and the right time to start these interventions, right? And I think one big step forward from the renal community over the last couple of years has been sort of being able to standardize some definitions for sepsis associated AKI, right? Because up until now, we've had this like hodgepodge of definitions and patients that get included into clinical trials, or prospective studies that they the only thing that they really share is a diagnosis of AKI. But other than that, it's they're different definitions of when sepsis came on, what parameters are using to monitor AKI. And so kind of this definition of sepsis-associated AKI, of AKI happening within the first 7 days, or the 7 days after sepsis onset, and kind of subdividing that between early sepsis-associated AKI and late sepsis-associated AKI, I think should serve as a framework, so that people can kind of be able to subclassify these patients on this very distinct phenotype, to better understand what therapeutics can be applied early in sepsis-associated AKI, late in sepsis-associated AKI, and sort of being able to just understand this pathologic process better.
Yeah, okay. Well, exciting. So I can't wait to hear like what happens in the next 10 years or so. All right. Next thing I want to chat about. Let's talk about urine output goals. Okay. So I'm a nurse. I've worked at the bedside for a lot of years. And it's traditionally we all have these orders that say standing orders that say call for urine output less than 30 mils an hour. And I'll be honest, as a nurse who worked night shift for 14 years, I will milk that fully to get 30 mils so I don't have to wake up and attending in the middle of the
Yeah,
night to
yeah,
say you're not
yeah,
putting it. But when you look at like all of the nephrology guidelines and the work that's being done there, you will not find 30 mils as a urine output goal anywhere. It's a half a mil per kilo per hour. So tell me, like, what are your thoughts on urine output goals? Because I think we've got to think about body surface area and like I'm 5'2", is 30 mils an hour a good goal for me? Probably. But what about that person who's 6'2", right? So what are your thoughts on urine output goals?
yeah, yeah. And I think in the same vein as sort of the way that we've used creatinine, urine output as a marker of sort of as a surrogate of kidney function, I think has the advantage of being a little bit more dynamic in real time than creatinine, right? We talked about how creatinine lags behind. Urine output tends to be a little bit better there, where if obviously if the patient is becoming oliguric, but that we're worried that maybe AKI is starting to sit in, but the reality of it that the urine output just has so many other determinants other than GFR, really, like how much are the kidneys working, because it depends so much, as you said, on sort of patient specific factors, like yeah, this patient is, but most importantly also like volume status, right? If a patient is severely volume depleted and they're really not making much urine, that's kind of probably the expected response, as opposed to if the patient is floridly overloaded and they're really not making urine. They, if those kidneys were working, if they were putting out urine, they should be putting out some amount of decent urine output, right? So um, we typically, at least in my practice, I don't necessarily go off of a specific sort of urine output goal for hour per hour, but definitely, obviously, in the setting of declining renal function, right, from a synthetic perspective, or clearance perspective, I should say, where the kidneys are, we see that the potassium starting to build up, and on top of that, they're becoming oliguric by the hour. I think that is our sort of indicator that the patient's AKI is progressing, and that we should try to be either proactive about what we're doing, or also just start monitoring more carefully and treating to see if there's anything that we can do to improve kind of these sepsis-associated AKI risk factors, right? Modify them if possible.
Okay, cool. All right, next topic I want to chat about fluid choice
Yeah,
for resuscitation and sepsis. This is a hot topic right now,
yeah,
right?
yeah.
So is saline normal or should we be thinking about other fluids? All right, what are your thoughts as a nephrologist?
Yeah, as a nephrologist, right? So I think a lot of our colleagues look to us for guidance about this, right? Because we tend to be the ones to come up with these like sort of weird fluid combinations, sometimes to recommend to our ICU colleagues or whatnot. But the reality of it, I think, is that when we think about fluid in AKI, specifically in sepsis associated AKI, I think there's a couple of things that we need to be mindful of, right? So one is first and foremost the amount of fluid that we're giving our patient, right? So I think especially this consensus group for sepsis-associated AKI from ADQI, sort of recommends aggressive resuscitation, similarly to sepsis guideline goals, right? Even for patients that have AKI. But the key here is that we have to be mindful and very careful about preventing fluid overload, right? Because in this patient that has AKI that is becoming oliguric, it's very easy to, just pump them up with fluids. And then by the time that we realize they're overloaded, and we're just precipitating the need for kidney replacement therapy. So there's this kind of like phased approach that has been proposed where, we resuscitate them aggressively, we sort of optimize them, we stabilize them, but then we de-escalate very quickly, right? So if they're either to prevent precisely volume overload, because if they're getting overloaded, we know that fluid, positive fluid balance across in AKI across the spectrum is a poor prognostic marker, right? It increases mortality, it increases ventilation days, it increases ICU length of stay. So we do want to be careful about not overdoing this, right? And specifically in the oliguric patient, because if a patient that doesn't have AKI, maybe we can get away with it because they just continue to make urine, right? But if they're having AKI, this is going to happen way, way more quickly. And then I think in terms of the fluid choice specifically, yeah, right after, some of these studies came out, Salt ED,
Smart.
yeah, Smart Trial, all of these started coming out. I think there was this shift towards, maybe we should be staying away from things like like normal saline that have, this high amount of chloride in them. But I think the reality of it is that first and foremost, Smart and Salt ED had small amounts of patients that had specifically sepsis. So we don't really know if these necessarily patients with sepsis associated AKI do better or worse with balanced solutions versus normal saline. And I think some of the recent sort of meta analysis and evidence that we have haven't really shown a substantial difference. But I think the bottom line is that we should really think about sort of what our patient's biochemical profile is at the time that we need to initiate fluids, right? If they are hypochloremic at the time of needing fluid, probably normal saline is the way to go, right? If they are developing worsening acidosis already when we need to fluid resuscitate them, maybe something like a bicarbonate-based solution is preferable. Albumin has also been shown to have some mortality benefit, but it should be used in the right setting as well.
Which is looking like shock would be that setting right now, correct?
Right, correct. Like, especially if we think either as an initial fluid choice or as sort of an adjuvant after your initial fluid of resuscitation. But I think kind of like with everything in AKI, it has to be this individualized approach, right? Where we just kind of have to look at the patient itself, and then based on what the patient needs are, then we should probably pick one or the other, because I think outcomes across kind of those four big fluid categories tend to be about the same. Starches and dextrans, those I think we're staying far away from, and we probably shouldn't be used because they increase the risk of AKI as well. So, but those would be my kind of like my 2 cents in terms of managing fluid in AKI, or specifically sepsis associated AKI.
Yeah, well, I think a lot of protocols have really moved away from saline, and like you said, just perhaps using it. When I say protocols, I mean like sepsis protocols for resuscitation have moved away from saline unless the patient specifically is hyponatremic or hypochloremic. They're using more balanced like LR, plasma, even normal sol. We're seeing a little bit more too. All right, well, we're going to go to break. And when we come back, we're going to pick up where we left off. And we're going to talk about some other topics. Specifically, I want to talk about the whole idea of using stroke volume to guide resuscitation. And then we're going to dive into CRT and HG. When is the right time to start it? Should we be thinking about the possibility of dialyzing off these bad these bad cytokines and cellular mediators? And what does that look like? So I'm so excited to come back and pick up where we left off. Are you a healthcare professional who wants to stay ahead of the curve? Visit sepsispodcast.org to learn more about how you can receive free CME and nursing CE credits by listening to or watching the Sepsis Spectrum. It's our way of supporting you and together better understanding the ever-evolving world of sepsis care. And now, back to the show. Welcome back. So we're going to pick up where we left off. And one of the things I wanted to chat with you about is the whole idea of using like a stroke volume measure with the passive leg raise test, or by manually bolusing a patient very rapidly to decide fluid needs in the setting of hypotension. And a lot of us knew about the FRESH trial where they used one of the non-invasive stroke volume measures. And what they found was that they were able to statistically significantly reduce the need for intubation, mechanical ventilation, but they cut by half, and then when they used a stroke volume measure to guide fluid response, fluid resuscitation, and they also significantly cut dialysis needs. And you had mentioned earlier that fluid overload is definitely a risk factor for kidney injury. But what are your thoughts? Like, is it time that we just invest in hemodynamic monitoring and appropriately guide fluid resuscitation? Or what are your thoughts on that?
Yeah, I think it's definitely, something that is gaining more and more traction, right? We've realized that with the current metrics that we have, measurement of things like, hemodynamic monitoring with things like CVP, for example, have become they're not as reliable, but they are necessary, right? Because precisely, you know, volume sort of volume overload is really sort of it's a complication in and of itself of AKI, but it also it worsens prognosis for AKI, right? Delays renal recovery. The more renal congestion there is, the more ultrafiltration we would need to do if the patient were started on renal replacement therapy, and that usually leads to sort of more cross, multi-organ sort of failures. So I think, yeah, finding the right balance between tools that we can use for hemodynamic monitoring and how those will inform choices for fluid um, management, I think is probably going to be the one of those important topics that should be able to help us in the future prevent AKI and also manage AKI when even when AKI is setting in, to manage it more effectively, for sure.
I think we've all decided like it's time to stop using CVP to decide if a hypotensive patient needs volume. But I think where we're using CVP a lot more is when we've got that patient that we're trying to really stabilize and maybe de-escalate. And I know one of the things we're seeing is like when we see high CVPs, we know that their risk of kidney injury is extremely high.
Right. Yeah. And we probably should should stop pumping them with more fluids, right? And really being proactive about using things like, diuretics, for example, because I know a lot of people are kind of a little bit weary about using diuretics in the setting of AKI, but really diuretics can be one of those tools that can help us in the right setting, again, kind of prevent further volume overload that would precipitate the need for something like kidney replacement therapy.
Yeah. All right. So what are your thoughts? Intermittent pushes of a diuretic or a drip?
Yeah, and I think it's a big question. What I'll tell you in practice, what we do here is you rarely do we put them on a diuretic drip when in the setting of kind of sepsis and AKI. I think our kind of workflow here is usually kind of we abide pretty much with the furosemide stress test, right? So we're getting a patient that's becoming oliguric, that's probably developing some degree of AKI. We tend to bolus them with a milligram per kilogram of furosemide and kind of assess their response. And if they put out, more than 200 mLs of urine within the first 2 hours, then we know that we have a little bit more time, or their chances of turning around in terms of their AKI are way, way higher than if we do that on a patient that's overloaded and they literally make no urine, then we kind of know that that's our call for potentially starting them on some form of kidney replacement therapy.
All right, so that was my next question is when do you decide it is time? They've got to be on some sort of a renal replacement therapy.
Yeah, and I think that's been a big question that the nephrology world has been trying to answer for many, many years. And the truth is that as as little as 10 years ago, we didn't really know the answer to that, right? But since then, at least 5 or 6 big clinical trials have come out that have tried to sort of answer that question. And that's, well, if we have a patient that has developed AKI, we know that if they're developing severe complications such as severe hyperkalemia, they're overloaded, if they have pulmonary edema that's affecting their ventilation, if they have severe metabolic acidosis, they're uremic, there really is no question. We should put them on some form of renal replacement therapy. But what about those patients that we think are heading that way? They're a little bit hyperkalemic, they're not making as much urine. Is there any benefit of really starting them early, right? Maybe we can prevent some of those complications. Maybe they're not going to get as sick and we can get them out sooner and maybe lead to earlier renal recovery. But I think the overwhelming evidence, especially of in the ideal ICU trial that actually included patients with septic or sepsis and septic shock, is that there really is no benefit in terms of mortality of starting them earlier rather than kind of waiting some until they maybe develop some of these more clear indications for renal replacement therapy, right? Because and the reason being is that a number of patients that we think have AKI but maybe are not going to turn around actually don't end up needing any form of renal replacement therapy, right? 30 to 40% of the patients that were randomized to these arms of like more the conservative strategy where we're actually not going to do renal replacement therapy didn't end up going. Whereas if they would have been randomized to the more aggressive arm, they had already been started on renal replacement therapy. And that didn't come at a cost of more complications from the group that was kind of waiting longer to start CRT, right? So I think we're starting to understand both on the very acute and also on the recovery side that actually probably less dialysis is better overall for the patients, but that we do have to intervene um, in a timely manner, right? Because delaying it too long, right? There's this kind of like
Sweet spot. Yeah.
kind of Goldilocks kind of period. Yeah, sweet spot, right? Where if we find we start them on that period, we can improve them. But if we but too early or too late can actually be counterproductive, right? And lead to more complications and higher risk of mortality as well.
Oh, interesting. Okay, so like what would that look like clinically at the bedside? Let's say you get consulted, you come to the bedside. Are you going to try a Lasix challenge first?
Usually, yeah. I think that would be usually 'cause that's kind of the way that we think about them, right? So again, if they have any of those severe complications and they have an AKI, right? Their potassium is like 6.5, they really are struggling with that, then I think there's no question we should just put them on. But if their potassium is like say 5.3, their creatinine has gone up to like about 3.5, they're making some urine, but maybe in the last 24 hours they just made 600 mLs of urine, right? They're starting to get overloaded. Probably that's a good place to do something like a furosemide stress test. If we had reliable biomarkers, that would also be one place to use them maybe. And typically, if they don't respond to that furosemide stress test, then we kind of know like, oh yeah, so we probably should get them started sooner rather than later because this is probably not going to turn around anytime soon. And then, yeah, and that's usually when we put them on either, you know, CRRT, continuous renal replacement therapy, or hemodialysis. Here at our institution, we have, wide availability of CRRT. So most patients that are hemodynamically unstable, that they're on pressors or they're requiring some degree of ultrafiltration, but we need to control that a little bit better. We tend to start them on CRT, then move them over to kind of our transition therapy, which is prolonged intermittent renal replacement therapy or SLED. And then ultimately, as the patient sort of continues to recover and get more and more hemodynamically stable, we transition eventually to intermittent hemodialysis 3 times a week. And that allows us to monitor them for renal recovery as well a little bit better because we are able to see what the clearance is and what the volume output is on days where we're not doing dialysis.
That was I like how you outlined that. That's actually really nice. I think for a lot of people at the bedside just to understand from a nephrologist standpoint, that's kind of your approach. Now, how long are you running patients on SLED? How many hours do you usually run them?
So SLED in our program, it usually runs anywhere between 6 to 12 hours, and we actually do have a nocturnal SLED program. So that's been sort of beneficial in the sense that, for example, it frees up our patients during the day to work with PT, to go for their radiologic imaging procedures, and then when they're going to be in bed sleeping mostly, that's when we're doing their SLED. So we were able to optimize kind of resources around their care as well.
I love that. Okay. And then when you're initially making that decision, do you like let's say you've got somebody who's got acute kidney injury, do you almost always default to CRRT over HD?
I would say so. There's no clinical data that tells that there's a mortality benefit between CRT and HD, right? So depending on the resources available at each institution, there's probably not a wrong answer. But the reason why we tend to go for CRT is primarily because it tends to be a little bit better tolerated from a hemodynamic standpoint. But also importantly, I think, especially on talking about these patients that are overloaded, it gives us way more flexibility to do a little bit of ultrafiltration every hour as opposed to having to do a ton of ultrafiltration that might not be as well tolerated from a hemodynamic standpoint, right?
They
And
get
it
hypotensive and
allows
they're
us,
giving them volume
yeah,
back and yeah,
exactly. And then
the
we're like
whole
just kind of doing this back and forth. Yeah, we're just so we found that you know in our program, starting most of our patients on CRT tends to be kind of our standard, and then as we kind of mentioned, transition them to SLED, and then eventually HD. I would say the only scenarios where we do HD upfront are if we need, a lot of clearance, right? It's a drug intoxication or they're severely hyperkalemic. Because CRT, the reality of it is that the correction of these electrolyte disorders tends to be, yeah, slow and progressive. So.
Okay, so let's say you could control the future.
Mhm.
And, like, what would you like? Where would you like to see things go? Like, what excites you in the nephrology world about like what's coming down the pike? Because I'm sure you've got your finger on the pulse of like what's happening in research and everything. Like, what excites you, and what would you like to see happen in the next 10 years?
Yeah. So I think what I would love to see is for us to be able to have therapeutic targets or agents to treat AKI early on, right? Since we've started to understand that this is more like a multi-system disease that is happening, subclinically many times before we even start picking it up with our current sort of tools. I think early recognition, so kind of being able to finally mainstream some of these biomarkers to really help us sort of catch it early, and then something that we can do about it, right? So like some of these either anti-inflammatory medications or immunoregulatory medications that could allow us potentially to improve or to prevent AKI from setting on. And if it does, that it's less severe, so they don't actually end up needing some form of kidney replacement therapy. I think that is ultimately what I would like to see. And I think what might end up happening now that we are understanding better kind of what the pathophysiology of AKI is in these different disease processes, right? Because it's different, sepsis-associated AKI from, for example, cardiac surgery-associated AKI. There's different, even though up until recently we thought of them kind of at the same common pathway, and we should just kind of treat everybody the same. So I think we're hopefully with better definitions, but with sort of being a little bit more precise about how we're defining these events, we're able to find these things that are able to differentiate them and allow us to intervene on the disease process.
All right, so I'm going to wrap it up with this. We've already decided that they could call you earlier. We've decided that already. I think I kind of decided that for you.
Yeah.
This is in honor of Dr. Fleet, who I worked with forever. But if you could give a couple pieces of advice to bedside clinicians who have a septic patient who is developing AKI, and you can decide how many, like what are the few things that you're going to say, think about this, this, and this. These are my takeaways I want you to think about before you make that decision to call me. Don't delay calling me, but these are some things I want you to think about. What are they?
So I think the first thing is that when a patient develops AKI, we have to be aware that the fact that they already developed AKI means that this patient is probably going to do worse compared to a patient that does not develop AKI, right? And it's not just something transient. So we have to be really proactive about sort of managing it and expecting potentially some more associated complications, right? So I probably need to pay more attention to the fluid balance. I probably need to pay attention to make sure that I can sort of tweak anything that I can in terms of antibiotic coverage or whatever. So in order for this process to not progress as much, right? And I think the second part of it is, well, as we, I guess, sort of understand sepsis-associated AKI a little bit better, probably earlier intervention is going to be something that's going to allow us to change the prognosis. Because as we were just chatting about, when that patient is kind of already on the pathway of needing kidney replacement therapy, there's very few things that we can do to improve the recovery and their prognosis, rather other than just kind of sort of seeing them recover. But prevention or avoiding going into that state is probably one of the things that could kind of get them out of that pathway, especially if we're able to identify risk factors that would put them at risk, would increase their likelihood of developing AKI.
Well, I think this is great advice, and I'll be honest. I always like, where's the nephrologist? Let's get him in here, because I just think he brings so much. You truly bring so much to patient care, and in long term, like I personally cannot imagine having CKD and being dialysis dependent and having to go to a facility 3 times a week to dialyze. Like I personally cannot fathom that. And anytime we can prevent that, I think it's a huge win. It's a gigantic win.
Yeah.
I just want to thank you for being here. I know clinicians are going to get so much out of this interview. So I just thank you for your expertise and everything you do clinically. You definitely are appreciated.
Thank you so much for having me, and it's been a pleasure.
That was a really fun episode and discussion. And I think so many times, we get nephrology involved later in the game. And I just felt like Dr. Matzumura gave us a lot of really helpful information and things to think about. And I'm also really excited about what's coming in the future as far as maybe earlier biomarkers that can detect acute kidney injury so that we can intervene earlier and maybe prevent CKD. And so there's so many things we can do at the bedside, like preventing fluid overload, supporting patients from a hemodynamic standpoint, and truly, just early recognition of acute kidney injury. So I want to thank you for joining me on today's episode of the Sepsis Spectrum. If you have a story you want me to read on the air, visit www.human-content.com/sepsis. And if you're enjoying the Sepsis Spectrum, we want to hear about it. Please leave a review wherever you're enjoying this podcast. It helps a ton. You can also reach me and our awesome team at info@sepsis.org or visit sepsispodcast.org to share any stories of your own, questions, concerns, or episode ideas. To learn more about Sepsis Alliance, visit sepsis.org. The Sepsis Spectrum is brought to you by Sepsis Alliance. I'm your host, Nicole Kupchik. Our executive producers are Allison Strickland, Hannah Sass, Claudia Orth, and Alex Colvin. Our producers are Aaron Corney, Rob Goldman, Shanti Brook, and me, Nicole Kupchik. Our post-production producer is Sundas Hasoon Noli. Our editor and engineer is Jason Portizo, and our music is by Omer Benzvi. To learn about Sepsis Alliance's podcast, legal disclaimer, and compliance policies, you can visit sepsispodcast.org/disclaimers. The Sepsis Spectrum is a Human Content and Sepsis Alliance production. Thanks for watching. I hope you're enjoying the Sepsis Spectrum. Leave a comment below and let me know. If you want to binge some more episodes, just click that playlist right over there. And if you're feeling super generous today, give this video a like, subscribe if you haven't, hit the bell, all the things. And of course, you can also listen on the go wherever you get your podcasts. Bye.